Hi, good night guys. Tonight we'll be talking about the temporomandibular joint. So just to start off, I'm just going to be telling you my sources, which will be the dentist's head and neck anatomy, as well as Google images. So first off, let's start by discussing what forms the temporomandibular joint. First off, the bones of the skull that are involved in the temporomandibular joint would be the squamous portion of the temporal bone, as seen right here. This is the squamous portion of the temporal bone, but this, along with the condyle of the mandible, seen here, the articular disc, not seen in this image, and the ligaments, not seen in this image, form temporomandibular joint. The temporomandibular joint is located on the squamous portion of the temporal bone. It has an articular surface which is avascular and composed of fibrous connective tissue. It has a load-bearing area, or multiple load-bearing areas, and there are three. On the lateral aspect of the squamous portion, which makes 1, the condyle, which makes 2, and the articular disc, which makes 3. So let's talk about the relations to the squamous portion of the temporal bone. Anteriorly, the temporal bone, as seen right here, is related to the articular eminence, seen right here, becoming the articular tubercle. The intermediate portion of the squamous portion temporal bone is the glenoid fossa, which forms the superior border of the temporomandibular joint, and posteriorly you find the tympanic plate tapering to the postglenoid tubercle, which is not seen in this picture. The articular eminence becomes the articular tubercle, and it's a bony prominence at the base of the zygomatic process. The articular tubercle in itself is found on the lateral part of the articular eminence and facilitates attachment of the capsule as well as the lateral temporomandibular joint. Now, the glenoid fossa, as mentioned before, is a depression into which the condyle it moves. So superior to the glenoid fossa, you actually enter the cranial fossa, and you enter, to be more specific, you enter the middle cranial fossa. The tympanic plate, which is a vertical plate, is located anterior to the external auditory meatus, located right here. And the postglenoid tubercle, that seen in this photo right here, is an inferior extension of the squamous portion of a temporal bone, and it pretty much forms the posterior aspect of the glenoid fossa, seen right here. So the mandibular condyle, there are two, lying on both sides of the skull. If you look at the picture that I'm about to show you, you'll notice that the medial lateral diameter is actually longer than the anterior posterior diameter. The anterior posterior diameter is about 1 centimeter or 10 millimeters, while the medial lateral diameter is about 20 millimeters. It is football shaped, and it comprises fibrous connective tissue, which forms the main load-bearing area. And the main load-bearing area is actually formed on the lateral aspect of the condyle. Found between the condyle and the glenoid fossa is the articular disc, seen right here. The articular disc is formed once again by fibrous connective tissue. As mentioned before, it's formed between the condyle and the squamous portion of the temporal bone, and it's avascular centrally and neurocentrally, but in the periphery of this disc, it is vascular and well innervated. Load bearing is actually minimal peripherally in the areas that are vascular, but very, very high in the area that is avascular and aneuro. The main load bearing area is actually lateral, and this area is the area which has the highest risk for perforation. Now, the periphery of the capsule, of the articular disc, merges with the capsule itself. Now, here are the portions of the articular disc that you need to know. There's an anterior, intermediate, and posterior portion. The anterior portion is thick and lies anterior to the condyle, seen here. The intermediate portion is thinnest and located along the articular eminence, so it follows it inferiorly. And posteriorly, there's a thick band located superiorly to the disc, right here. Medial and lateral collateral ligaments actually attach to the disc, and they attach the disc to the condyle. Anteriorly, the disc is attached to the capsule and superior head of the lateral pterygoid, seen here. Posteriorly, The disc is continuous with the bilaminar zone that blends with the capsule, as seen here. The bilaminar zone is or posterior attachment zone, has a superior lamina, not seen very well in this diagram, but I'm going to look for a nicer diagram to show you. 1 second. This is the bilaminar zone right here, the posterior attachment. So you have a superior lamina, which is made of elastic fibers, and an inferior lamina made of collagen fibers. Now the superior aspect or superior lamina anchors the superior portion of the posterior capsule, while the anchors the superior portion of the posterior portion of the distal, the capsule, the bone at the glenoid tubercle, as well as the tympanic plate. The inferior lamina, which is made of collagen fibers, please note that they are made of two different things. One is made of elastic and one is made of collagen fibers, anchors the inferior aspect of the articular disc to the condyle, seen here. So the superior lamina is, as I mentioned, is made of elastic fibers, and it anchors the superior portion of the posterior portion of the disc, seen here, to the capsule, not seen in this picture, bone at the postglenoid tubercle, seen here, and the tympanic plate, seen here. The retrodiscal pad, which is a highly vascular newer portion of the temporomandibular joint, is located here. The temporomandibular joint has many compartments, and the articular disc divides the temporomandibular joint into a superior and inferior compartment. Now, the superior and inferior compartments contain, or the disc itself contains, endothelial cells that form the synovial lining, and they actually produce synovial fluid within the capsule. So let me repeat that one more time. There's an articular disc which divides the temporomandibular joint into a superior and inferior compartment, and it contains endothelial cells, these compartments contain endothelial cells that form synovia or endothelial lining, which produces synovial fluid. The superior compartment usually contains approximately 1.2 mils of fluid, while the inferior compartment contains usually 0.9 mils. And of note, it must be mentioned that the inferior compartment, which is involved in the initial movement of the jaw in terms of opening for the first 20 millimeters, is involved in rotational movements, while the superior compartment is involved in translational movements. Now let's talk about the capsule. The capsule in itself encloses the articular surface of the temporal bone, as well as the condyle. It's composed, as you notice, a general trend of fibrous connective tissue. The medial and lateral aspects are reinforced by ligaments, and it itself is lined by highly vascular synovial membrane, which contains sensory receptors and nociceptors, meaning that it can, one, relay pain and sensation to the brain. The capsule's attachments superiorly is attached to the rim of the temporal articular surfaces, inferiorly along the condylar neck. Medially, it fuses with the medial collateral ligament, and laterally it fuses with the lateral collateral ligament. Anteriorly, it fuses with the superior head of the lateral pterygoid. Posteriorly, it fuses along the retrodiscal pad. The ligaments of the temporal mandibular joint must be mentioned carefully. So there are four main ligament categories, not necessarily four main ligaments, but the main categories that we're going to discuss: the collateral ligament, the temporomandibular ligament, the stylomandibular ligament, as well as the sphenomandibular ligament. The collateral ligaments, the medial collateral ligament, connects the medial articular disc to the medial condyle. The lateral collateral ligament, seen here, connects the lateral articular disc to the lateral condyle, seen here. The temporomandibular ligament, I'm going to look for a better picture. The This is the best one we have here. The temporomandibular ligament, not seen in this picture, is divided into two. The purpose of it is to inhibit lateral and posterior movements of the joint. It has two parts, the oblique, or the outer part, and it has a horizontal and an inner part. The oblique outer part is actually the larger portion, and it limits opening of the mandible. And the inner, smaller part limits posterior movement of the articular disc and condyle. So the oblique portion runs from the articular tubercle, as you know, right here, to travel posterior inferiorly to the condyle. Hence its term is oblique. While the horizontal portion of the temporomandibular joint ligament travels from the articular tubercle horizontally to the lateral condyle and disc. The stylomandibular ligament seen in this photo or picture runs from the styloid process to the posterior margin of the angle and ramus of the mandible, and this limits protrusion of the mandible. So as you now know, the temporomandibular joint ligament inhibits lateral and posterior movement, and the stylomandibular ligament inhibits anterior displacement of the jaw or protrusion. The sphenomandibular ligament, seen here, runs from the spine of the lingua to the lingula of the mandible, and it's basically a remnant of Meckel's cartilage. And it acts as a pivot on the mandible, so it remains tense through opening and closing of the mouth. We're now going to talk about the blood supply of the temporomandibular joint, seen here. As you remember, the branches of the external carotid, you know that the external carotid terminates into the superficial temporal. I wish this picture was a little bit clearer. So the blood supply of the temporomandibular joint would be the temporal branch of the external it should be the terminal branch, of the external carotid artery, which is the superficial temporal. There's also the deep auricular, seen here, as well as the anterior tympanic, seen here. These are branches of the maxillary artery and other branches, and basically I'm going to talk about the other branches of the maxillary artery. This picture also shows the branches or the blood supply of the temporomandibular joint. So it spells basically SAD. So superficial temporal, anterior tympanic, and deep auricular. So deep auricular here, anterior tympanic, and then anterior tympanic, and the superficial temporal. So I hope you're following me so far. We're going to talk about the branches of the maxillary artery. I have an acronym for the first part, because you can see it's divided into first, second, and third part. The first part has an acronym which is spelled AMADE. A would be the anterior tympanic, M, middle meningeal, A, accessory meningeal, I, inferior alveolar, D, deep auricular. So it spells AMADE. The second portion is it doesn't really have a nice acronym, but I say a PAP BM, which will be the posterior deep temporal, the anterior deep temporal, the pterygoid, the masseteric, we can go to bostinator first, and then the masseteric, which spells BM. So PAP BM for the second portion. PAP, PAP, BM, BM. The third portion has a nice acronym, and it spells the Pampas. So D would be deep palatine, the P would be posterior auricular, posterior superior alveolar, A will be the anterior superior alveolar. I'm looking for the branch here, but I'm not seeing it. So the anterior superior alveolar, the M will be the middle superior alveolar, the P will be pharyngeal, the A will be the artery of the pterygoid canal, and the S will be sphenopalatine, or the nasopalatine artery, or is also known as the artery of epistaxis. Okay. What is the innervation of the temporomandibular joint? It's basically the mandibular division of cranial nerve 5. So the auricular tympanic nerve, or auricular temporal nerve, sorry, as well as the mesenteric and posterior deep temporal, which are branches of the anterior division of the trigeminal nerve. So the auricular temporal nerves, as well as the mesenteric and posterior deep temporal.